Welcome back to the Deep Dive. Today, we are looking at something pretty amazing, how simple chemistry, really just a splash of color, can solve the huge problem of finding invisible risk.
Right. It's about spotting a tiny, subtle abnormality that could easily be missed and how that can make all the difference.
And for this, we're pulling our information directly from some fantastic source material.
We are specifically from the video HCC 1472-15A3 sprays methylene blue and indigo carmine, which was uploaded on Dr. G.S. Raju's YouTube channel. It's an excellent resource.
Fantastic. So our mission is pretty clear, to really get to grips with two key dyes used in GI endoscopy. We're talking methylene blue and indigo carmine.
And this isn't just academic. These are critical tools for enhancing what a doctor can see, especially in patients we already know are at high risk.
Okay, so let's just dive right in. We have two dyes. What is the fundamental difference in how they, interact with tissue?
Well, they operate on completely different principles. Methylene blue is what we'd classify as an absorptive stain.
Absorptive, so the cells actually take it in.
Exactly. You can think of it like the cells are actively drinking it up. It gets taken into the cellular structures.
And that tells you something about the cell's function.
Precisely. It highlights abnormalities based on differences in, say, cellular metabolism. If a cell is acting differently, maybe becoming precancerous, it might absorb that dye differently than its healthy neighbors.
So it stands out like a little internalized beacon.
That's a great way to put it. It's a functional scan looking at what's happening inside the cell.
Okay, so if methylene blue is doing that, why do we even need the other one, indigo carmine?
And that's the crucial distinction. Indigo carmine is a non-absorptive stain.
Meaning it doesn't go in at all.
Not at all. This is vital to understand. It is not taken up by the cells. Its function is purely mechanical, you could say. Topographical.
So what is it doing then, if it's not being absorbed?
It just settles. It pools in the tiny folds, the recesses, the grooves of the tissue surface, what we call the epithelium.
Wow, okay, so one is like a spotlight on the cell's internal health.
And the other is like a contrast agent that highlights the physical texture.
The surface architecture. That is a powerful difference.
It's a perfect way to describe it. Indigo carmine highlights the physical geometry of the surface. It's all about the structure, not the cell's chemistry.
And that really helps explain why this is so necessary. I mean, we're not talking about finding some big, obvious tumor here, are we?
Not at all, and that's the whole point. The conditions we're looking for with these sprays often start out as flat lesions.
Flat, so they don't bulge out.
Right. They lack mass, they're incredibly subtle, and honestly very easy to miss with the naked eye during a standard white light endoscopy.
So a routine screening might just pass right over them.
It happens. The subtle change in color or texture just gets camouflaged.
Yeah.
We use chemical contrast because the physical contrast just isn't there.
Which brings us to the high stakes question. Who needs this? I mean, this isn't for everyone, right?
No, it's highly focused on specific high-risk groups.
Okay, so who are we talking about?
There are two main groups. First, people with long-standing inflammatory bowel disease, or IBD.
So ulcerative colitis, Crohn's disease.
Exactly. Specifically, patients who've had active ulcerative colitis or Crohn's colitis for at least 8 years.
8 years, that's a key number.
It is. That chronic inflammation really increases their risk of developing these flat precancerous spots over time.
And the second group?
The second group are patients with Lynch syndrome. You might also hear the older term, hereditary non-polyposis colon cancer, or HNPCC.
So this is a genetic predisposition.
It is. It's a syndrome that puts people on a pathway to cancers that often start with these exact kinds of hard-to-see flat lesions.
Okay, so the goal here is broad detection. You're scouting. When you're just scouting like that, does the concentration of the dye you're using matter?
It matters tremendously. When you're trying to cover a large area for detection, you want a light contrast.
Right, you don't want to overwhelm the view.
Exactly. So the protocol is very specific. For that initial lesion detection, you must use a highly dilute concentration of indigo carmine.
Like a light watercolor wash, maybe? Just enough to settle into the grooves.
That's a perfect analogy. And in practice, we use an indigo carmine 0.03% solution. The whole point is that it's a gentle wash, barely tinting the background.
I want to pause on the procedure itself for a second. Because you've mentioned two different dyes, and now we're talking about two different concentrations of one of them.
Yes.
In a busy clinic, with syringes being prepped, that sounds like a place where a mix-up could happen.
That's a critical point, and it speaks to why safety protocols are non-negotiable. The source material really emphasizes the absolute need for proper labeling.
Because one syringe looks just like the next.
Precisely. You might have the dilute wash in one and the concentrated solution we're about to talk about in another. You have to know which is which.
So you need a clear system.
It's mandatory. You fill the syringe and you immediately label it. The solution name, the concentration, the endoscopist's initials. It's a simple safeguard, but it's essential.
That makes perfect sense.
Yeah.
Safety first. So let's say we've done that. We've used the dilute indigo carmine wash, and bingo. We've found a subtle, flat lesion. Now what?
Now the mission changes completely. We shift from detection to lesion characterization.
Okay.
Once a lesion is found and we're not sure about its extent or if there's advanced pathology like cancer hiding in it, we switch strategies.
So we go from a wide-angle scouting lens to a super-focused macro lens.
That's it exactly. We stop searching and we start analyzing. For characterization, we need a much, much more concentrated solution.
More concentrated. Why is that?
The goal now is to define the lesion's borders and, critically, to analyze the structure of the tiny pits on its surface. Those patterns tell us about the cell organization underneath.
So let's talk numbers. You said 0.03% for detection. What are we jumping to for characterization?
We jump up significantly. For characterization, it's an indigo carmine of 0.13% solution.
Wow, okay, so that's what, more than 4 times stronger?
It is. It's a huge difference. And visually, the color is significantly darker, much denser. It's no longer a watercolor wash.
What does that stronger concentration do?
It forces the dye deep into the microarchitecture of that one specific lesion. It acts almost like an etching tool, highlighting every tiny pit and groove in extreme detail.
So you can see patterns you'd miss with the dilute spray.
Absolutely. And these patterns are crucial. They correlate directly with the severity of the pathology. This is what helps the endoscopist define the borders for removal and look for features that suggest cancer.
It's really a roadmap for diagnosis and treatment. So when we put it all together, what's the big picture here?
The big picture is that this dual approach turns what was once a diagnostic nightmare into a targeted, manageable procedure.
Right.
We have the dual function, a dilute spray, the 0.03%, for broad detection in our high-risk IBD and Lynch syndrome patients.
To find the nearly invisible lesions.
Then, once we find one, we switch to a highly concentrated spray, the 0.13%, for focused characterization of that specific lesion.
A brilliant blend of surveillance and really forensic analysis.
It is, and it vastly improves outcomes for patients who might otherwise miss that early diagnosis when the condition is at its most curable stage.
It really just speaks volumes about the power of contrast in medicine.
It really does.
Okay, so our deep dive today was all about how these staining techniques help us manage really tough conditions by revealing texture and structure inside the GI tract. Now here's something for you to mull over. We learned that a non-absorptive stain, like indigo carmine, is all about highlighting surface geometry. How might we use that exact principle revealing texture instead of chemistry to develop new, maybe low-cost screening tools completely outside of GI? Think about detecting subtle surface changes in places like the oral cavity or even the cornea. That's something to think about until our next deep dive.